Hi everyone, this is Maral, Rosie, Joanna, and Alex, and we just want to welcome you to our presentation on exercise and pain management. As stated by the APTA, the ongoing opioid crisis reflects the unintended consequences of a nationwide effort to help individuals control pain. The opioid epidemic is currently a big topic of discussion in the field of physical therapy, and as a group, we wanted to understand the physiologic mechanisms that contribute to the body's pain response and how us, as physical therapists, can work to help decrease opioid drug use through physical activity as movement specialists. So here are some of the topics that we will touch upon today. First, we're going to start off by reviewing the physiology of pain and what happens in our body when we experience pain. Second, we are going to examine the endogenous analgesic pathways in the body, which include both the endogenous cannabinoid and opioid pathways. Then we are going to briefly go over the exogenous opioid pathway along with the effects of opioid use. Next, we are going to look at the effects of exercise on the body's endogenous analgesic pathways. And then finally, we're going to wrap it up and we're going to provide you all with some take-home messages regarding the clinical implications of exogenous versus endogenous opioids.
According to the APTA, pain is one of the most common reasons patients seek medical care. In a lot of cases, patients go to their primary care physician for their pain, where they are then prescribed some sort of painkiller, like opioids, and told that this will fix their pain. Instead of fixing the root of the problem, the drugs are often just masking the pain. On top of not treating the actual cause, opioids come with a slew of harmful side effects that can lead to addiction. With this increase in opioid prescription comes an increase in opioid addiction, which has created the opioid epidemic that exists today. As physical therapists, we have the opportunity to work with patients and fix the problems that could be causing the pain, but unfortunately, we are not always utilized. As future physical therapists, we need to be advocates for our patients, ensuring that they are getting the best treatment possible for their current condition. So this slide is just a review of things we've learned in other classes, but we wanted to go over it with you before we dive into the body's response to pain. First, a noxious stimulus is received by the nociceptors. Then, the stimulus travels from the site of injury via A, myelinated fibers, and C, unmyelinated fibers, to the spinal cord. Once the signal reaches the spinal cord, the ascending pathways transmit the nociceptive information to the brain. The signal is then sent to the cerebral cortex, where it is integrated and undergoes cognitive and emotional interpretations as stemming from a painful stimulus. But what happens next? What system does our body have in place to respond to these painful stimuli?
Now we are going to look at the endogenous versus exogenous pain pathways. There are two common ways our bodies respond to pain. Endogenous pathways are our body's way to provide pain relief or analgesia naturally through a series of neurochemical mechanisms, which is considered an endogenous pathway. Pain relief can also be elicited through exogenous pathways through the use of medications like opioids, such as morphine, fentanyl, or oxycodone.
There are two main endogenous pathways that elicit analgesic effects in response to pain. First, we have the endogenous opioid pathway. The main transmitter responsible for pain relief in this pathway is beta endorphins. They are released in response to certain signals, but there's more to come on that. The beta endorphins then activate mu opioid receptors, which provide the analgesic response. The other endogenous pathway is the endogenous cannabinoid pathway, which has recently been getting a lot of attention. The two main endocannabinoids we'll be looking at are anandamide and 2-arachidonyl glycerol, also known as 2-AG. These endocannabinoids are made on demand in the postsynaptic neuron in response to certain signals. They then go on to act on presynaptic receptors called the CV1 and CV2 receptors. Here we have the two molecular structures of the endocannabinoids. On top we have anandamide and the bottom is 2-AG. Now we are going to do a deeper dive into the endocannabinoid system. Although not widely taught in school, the endocannabinoid system is present in all humans and vertebrates. It is present throughout the brain, the central nervous system, and the periphery. We know that the endocannabinoid system plays a role in a host of homeostasis activities, one of which is pain modulation. Again, the system consists of endogenous cannabinoids, cannabinoid receptors, and the synthetic and degrading enzymes responsible for synthesis and degradation of endocannabinoids. Like mentioned in the previous slide, the two types of cannabinoid receptors are CB1 and CB2 receptors, and they are located on the presynaptic terminal. Endocannabinoids are created on demand and released into the extracellular space. This contrasts with classical neurotransmitters that are synthesized ahead of time and stored in synaptic vesicles. Endocannabinoids also go against the flow of typical chemical synaptic signaling. A neuron that releases a chemical neurotransmitter, say glutamate for example, is designated as presynaptic. The neurotransmitter is released from the presynaptic neuron, and the receptor for that neurotransmitter is located on the postsynaptic neuron. Endocannabinoids, however, are synthesized and released from postsynaptic cells and travel backward, in the retrograde direction, across the synapse, postsynaptic to presynaptic. Physiologically, CB1 receptors act as communications traffic cops. They inhibit the release of many excitatory and inhibitory neurotransmitters, which can produce the analgesic response. Now, before we discuss the pathway, we just want to mention one thing about the two main endocannabinoid receptors, CB1 and CB2. They are G protein coupled receptors and very similar in structure. The main difference is where they are located in the body. CB1 receptors are mainly located in neurons and the GI tract, whereas CB2 receptors are located in immune cells and the immune system. Now, let's look at the picture to the left. Endocannabinoids are made on demand. They are not just hanging out in the cell waiting to be used. The body needs to make them when they want them. When the body receives a painful stimulus, neurotransmitters are sent to the presynaptic neuron. This can be seen in step 1 of the picture. These neurotransmitters signal the postsynaptic neuron to create the endocannabinoids, anandamide and 2-AG, represented by step 2 in our graphic. The endocannabinoids then travel backwards to the CB1 or CB2 receptor, represented by step 3 and step 4. When the receptor is stimulated, they inhibit the release of neurotransmitters in the presynaptic terminal, which has a ton of effects on the body. Agonist-activated cannabinoid receptors modulate nociceptive thresholds, inhibit release of pro-inflammatory molecules, and display synergistic effects with other systems that influence analgesia, especially the endogenous opioid system.
Now, let's take a look at a second natural pain response pathway. Here we have the endogenous opioid pathway, which involves the release of beta endorphins. So first, what exactly are beta endorphins? Beta endorphins are endogenous opioid neurotransmitters produced within the neurons in the central nervous system and in the peripheral nervous system. So here we have listed a little pathway for you, and we're going to go over that. First, the body experiences a noxious stimuli, or in this case, pain. This signals the hypothalamus to release corticotropin-releasing hormone, also known as CRH for short, in response to that pain. As a response, the pituitary gland synthesizes pro-opioid melanocortin, or also known as POMC for short, in response to a signal from the hypothalamus. The POMC is then cleaved into smaller proteins, and these smaller proteins become beta endorphins that are produced and released from the anterior pituitary gland. These beta endorphins are synthesized and stored in the anterior pituitary gland, which bind to mu receptors, creating the desired analgesic effect that we want. When the protein products of POMC cleavage accumulate in excess and we no longer feel pain, they turn hypothalamic CRH production off, and this is why the pathway is an example of a negative feedback loop. So the process stops as a response. Here is a more in-depth look at the binding of beta endorphins that occurs at the opioid mu receptors in the neurons. The picture that you see on the slide is an image of the synaptic terminal. On the right, we have the presynaptic neuron, and on the left, we have the postsynaptic neuron. The endogenous opioids are being released from the right in the presynaptic neuron, and the opioid receptors are on the postsynaptic neuron on the left. The binding of beta endorphins to opioid receptors causes the closure of presynaptic calcium channels and halt the release of excitatory neurotransmitters. This helps to suppress the transmission of pain signals. Additionally, opioid receptors enhance the efflux of positive potassium ions from postsynaptic neurons, which results in the greater suppression of the pain action potential. These two systems together help to boost the opioid analgesic effect. So when comparing the endocannabinoid system mentioned earlier and in the endogenous opioid pathways that I just mentioned, we see that the endocannabinoids go from the postsynaptic to the presynaptic neuron, while the endogenous opioid pathway goes from the pre to postsynaptic neuron. Here we have the exogenous opioid pathway, and when we think about exogenous opioid pathways, we typically think about the use of prescription, oral medications for pain, so prescribing patients with pain medications. So why are these opioids used to treat pain? So what happens is they bind to the same opioid receptors that naturally occur through the endogenous beta endorphin pathways, and they also activate structures further and deeper into the cell, structures kind of like the Golgi apparatus. And what happens with this is that it elicits a more intense analgesia or kind of a feel-good response, which could explain why opioids become so addictive to some patients who experience chronic or severe types of pain. Here we have listed a few of the cons of exogenous opioid drug use. The overuse of exogenous opioids can actually decrease the natural signaling and release of endogenous opioids. This is because the opioid receptors are already being bound to by the exogenous opioids. This pathway leads to effects like feelings of hyperalgesia, which we've touched upon in some of our other courses, which can actually increase a person's sensitivity to pain. It can also lead to tolerance because beta endorphins and mu receptors release with time. Addiction, again, which we talked about in the slide right before this because of its analgesic effects, and also withdrawal symptoms. So we've listed some of them here, and they can include things like low energy, irritability, anxiety, insomnia, muscle aches and pains, and etc. And some common types of opioid drugs that you might see in the clinic or you might see in your patient intake forms include morphine, fentanyl, codeine, and oxycodone.
So how can exercise help with all of this? Now that you are all familiar with the endogenous opioid and endocannabinoid pathways, we can dive deeper into exploring the effects of exercise on them. Exercise releases beta endorphins and anandamides into the bloodstream. Dietrich et al. Performed a study proving this by showing that trained male college athletes performing moderate intensity exercise for 50 minutes had dramatically increased concentrations of anandamide in their blood plasma. Taylor et al. Determined that the amount of endorphins that are released in our body are also exercise intensity dependent. This leads to a number of effects on our body. Exercise can lead to increased analgesia and improved mood, and many other beneficial effects on our cardiorespiratory system, which we have studied in depth in physiology this semester. Taking a closer look at the endogenous pathways during exercise, we see that they are suppressing pain both centrally and peripherally. Why? This is because the endocannabinoid and opioid receptors are located centrally in the brain as well as in the peripheral nerve terminals. These receptors are densely expressed on pain-sensing C fibers, which give us the slow, dull, achy pain. and then the large diameter fibers that give us that sharp stabbing pain. These effects of analgesia are dependent on the activation of the receptors in these endogenous pathways. Exercise induces antinociception. Antinociception is defined as the action of blocking the detection of a painful stimulus by sensory nerves. As physical therapists, we can measure the antinociceptive effects of exercise through patient-reported pain scores as well as pain pressure thresholds. A more recent study by Galdino et al. Shows that endocannabinoid levels are increased after resistance exercise, moderate aerobic exercise, and most frequently after high-intensity exercise. What specifically leads to antinociception in the endocannabinoid system? As we mentioned earlier in the presentation, endocannabinoids promote hyperpolarization and a reduction in the firing rate of excitable cells, which leads to inhibition of neurotransmitter release at the synaptic terminal. This leads to a reduction in nociception, which in turn leads to an increased nociceptive threshold.
We have all heard of the runner's high, and for many years the prime suspect has been endorphins. But what is the mechanism that brings about this response? A study by Taylor et al. Sought to investigate the effect of acidosis on endorphin release during high-intensity exercise. They tested this by having subjects work at high-intensity exercise and then again in another bout, but with a sodium bicarbonate buffer being injected intravenously and measuring the change in endorphin levels. We know that high-intensity exercise will bring to lower blood pH due to the accumulation of hydrogen ions in the blood. To combat this effect, the buffer acted to increase pH in the working muscle. The results showed a marked decrease in endorphin levels post and during exercise with the buffer, denoting a strong relationship between acidosis and endorphin release. How is endorphin release driven by acidosis? To start acidosis, we have an accumulation of hydrogen from increased metabolic activity. This causes a state of lower pH in the bloodstream, which is then detected by acid-sensing ion channels located on chemoreceptors at the carotid sinus. These chemoreceptors are specific to pH in the blood. The increase in hydrogen attaches to the acid-sensing ion channels to open the channels for sodium to come in and cause depolarization of the carotid sinus nerve. The signal goes up the carotid sinus nerve, then through the glossopharyngeal nerve to pH-sensitive neurons located in the medulla and hypothalamus. The hypothalamus reacts to counter acidosis by increasing respiratory rate to offload CO2. The hypothalamus is also the known controller of the pituitary gland, which is responsible for producing and storing beta-endorphin in the body. It has been hypothesized that the hypothalamus releases beta-endorphin as a ventilatory inhibitor to counter the risk of hyperventilation, because opioids are known to have an inhibiting effect on ventilation. This theory has been tested and has had mixed results. For example, one study observed naloxone, an opioid inhibitor, and the effect it would have on subjects during intense exercise. The subjects experienced no change in ventilatory response. If the hypothesis held true, there should have been an increase in ventilation associated with the inhibition of beta-endorphin. Although endorphins do have some inhibitory effect on ventilation without exercise, these results suggest that it is not the primary function during exercise. This also suggests that this response might be specific to pH that isn't associated with elevated CO2 levels. This has not been proven because the nuclei responsible for sensing pH are in the medulla, and nuclei that are sensitive to pH changes associated with CO2 are in the hypothalamus, but the signaling between the two to elicit an endorphin release has not been directly observed. It makes sense that these two areas of the brain communicate to release endorphin based on how the brain receives signals for acidosis and the observed effect with beta-endorphin release. If you take an evolutionary perspective and consider the pain effects associated with acidosis, it also makes sense why this response exists for humans, to run away from danger or would-be predators. You would not be able to run very far if this mechanism was not in place. The reason why this mechanism is in place and exactly what happens between the different parts of the brain demonstrate an area of further research and exploration, and it is likely that endorphins have a multitude of functions during exercise that are misunderstood and also difficult to isolate and study. Here is a useful visual we created describing the mechanisms that have been explained thus far. Feel free to pause the video for further study. The real question is, how can physical therapists use this system to their advantage? It has been well established that high-intensity exercise causes a strong endorphin response. Now that we know the mechanism for this response, it makes sense that therapists should prescribe exercise that causes acidosis, which is typically exercise above lactate threshold. Metabolically, we know that hydrogen ions will accumulate the fastest at this intensity. Studies have observed as much as a 7-fold increase in endorphin levels after intense exercise, leading to the possibility for patients to benefit from the pain-relieving effects of endorphins. The challenge for the therapist is how to implement this in patients who suffer from too much pain to do high-intensity exercise. What can the therapist do for these types of patients? It has been observed that endorphins respond best to high-intensity exercise, highlighting the role of acidosis, but aerobic activity can also contribute to endorphin release. It is a general rule that intensity is the main factor attributed to endorphin release, but acidosis can be achieved in other ways. It has been shown that moderate exercise can elicit endorphin response, but only when exercise duration approaches an hour in duration. At this time, endorphin levels begin to increase and rise exponentially thereafter. This doesn't mean we can forget about intensity though. A study by Kelso observed no endorphin response when subjects were working at 50% VO2 max for up to 2 hours. From this information, we can see that with enough time, an accumulation of hydrogen ions can induce some level of acidosis, creating an endorphin response, but a certain threshold of intensity needs to be maintained. This method may be useful for treating patients who are too weak or in too much pain to perform high-intensity exercise. Resistance exercise has also been shown to create an endorphin response, but only when subjects were lifting light weights for many reps and with short rest. This points towards a higher work rate as the key approach to creating an endorphin release due to acidosis. There has been heavy critique of the endorphin hypothesis due to fundamental study limitations and the emerging evidence in support of endocannabinoids. Take a minute to read the compelling argument brought forth by Dietrich and McDaniel. So why beta-endorphin and endocannabinoids? With the recent upsurge in endocannabinoid research and the heavy critique presented by Dietrich and McDaniel, we think that you cannot talk about one without the other. The emerging evidence contributing to the argument for endocannabinoids is confounding to the current breadth of research on endogenous opioids. The goal for us as physical therapists is to use these mechanisms to cause analgesia in the body. If it isn't clear which one is the true mechanism of analgesia in the body, then it is wise to consider both in our understanding of how the body naturally decreases pain.
Pause the slide to quiz yourself on what we've covered so far before we move on to the clinical implications. Now that we are familiar with the science behind exercise-induced analgesia, we are going to tie this knowledge into our future clinical practice. Our clinical example for today is low back pain. Low back pain affects around a quarter of American adults. The use of narcotics for treating back pain is on the rise. Just from the year 2000 to 2010, there was a 10% increase in their use. On top of the physical cost of low back pain on our nation, there is an undeniable financial cost. Low back pain in combination with neck pain accounted for $87 billion of American healthcare costs in 2013. Frogner et al. Published a groundbreaking study in December of 2018, pointing that greater than 60% of people with low back pain in America have a prescription for an opioid. After comparing differences in insurance claim for 150,000 patients for opioid prescription, healthcare utilization, and costs among patients with low back pain, the authors concluded that when patients with low back pain saw a physical therapist first, there was lower utilization of high-cost medical services as well as lower opioid use. Current research shows that exercise is the best way to manage low back pain, especially in the chronic population. That being said, many physicians still do not recommend exercise to patients who may be experiencing low back pain. As we studied in this presentation, exercise promotes analgesia through endogenous antinociception. Another way that exercise can provide analgesia is through strengthening the muscles surrounding the injury to correct any postural dysfunction, taking advantage of regional interdependence. In our low back pain example, research has shown that strengthening the lumbar extensors, core, and leg muscles promote stabilization and target low back pain. In 2016, the CDC released their opioid prescription guidelines, recognizing that prescription opioids are appropriate in certain cases like cancer treatment, palliative care, and end-of-life care, and in acute care situations if properly dosed. These guidelines further go on to say that for other pain management, non-opioid treatments, including physical therapy, should be used. Our conclusion to this drugs or exercise dilemma is, it depends. Opioid use still may be warranted with debilitating back pain, but should not replace exercise, as exercise is continuously showing to be the best way to truly treat with a goal to heal low back pain instead of only masking the pain. We put together a timeline for a comprehensive management of pain. This timeline can include both exogenous and endogenous analgesia. When experiencing pain, patients can use opioid medications prescribed by doctors to help produce an exogenous analgesic effect, providing them with instant pain relief. This analgesia will allow the individual to be able to tolerate exercise. As we focused on in this presentation, engaging in physical activity can activate endogenous opioid and endocannabinoid pathways. The stimulation of the endocannabinoid system is independent of the exogenous opioid pathway, thereby double dosing the patient to receive their maximal pain relief. We understand that pain is a complex system that cannot be cured solely by exercise. By utilizing both pharmacological interventions and exercise allows our patients to reduce their pain enough to exercise and be physically active in their community. This assists in healing the musculoskeletal injuries as well as stimulating the endogenous analgesia, thereby reducing their pain and their dependence on opioid for pain relief in the long term. The yellow star indicates where us as physical therapists come into play. We can help a patient in their timeline of pain management. We can make a difference in this population. Taking a closer look at our roles as physical therapists in the timeline of comprehensive pain management. As physical therapists, we are not prescribing opioids to patients. However, we're movement specialists. This means that by prescribing specific exercises, we can help our patients provide themselves with self-made pain relief. Our primary role in this timeline of comprehensive pain management is to get our patients moving. As we have learned in our modalities class this semester, exercise is not the only way we can assist in providing pain relief to our patients. Some modalities commonly used by physical therapists for analgesia include electrical stimulation, heat therapy, cryotherapy, ultrasound, and low-level laser therapy. Reducing dependence on opioid use for pain relief can be life-changing, as the road of opioid addiction is one that we should prevent every patient from going down.